This is Run the List, a new show type from Blood and Cancer. In Run the List, we'll bring you the latest in hematology and oncology news from MD Edge and Medscape. The stories in this show have been adapted for podcasts and are available in their full written form on MD Edge and Medscape. The show notes include links to stories, the original source material like journal articles, and relevant biographical information. New episodes of RTL will drop on Tuesdays, and your typical B and C shows with Dr. David Henry will continue to drop on Thursdays. I'm the host of Blood and Cancer, Nick Andrews. Today on Run the List, screening for lung cancer earlier can double eligibility. Lifestyle choices may reduce breast cancer risk regardless of genetics. The FDA approves an oral therapy for myelodysplastic syndromes, and what to say when patients ask for a mask exemption. Remember, you can contact Blood and Cancer by emailing us at podcasts@mdedge.com, and if you enjoy the show or the show type, or if you hate it, please let us know by emailing us, or you can leave a rating or review on Apple Podcasts. Okay, let's run the list. We begin today with proposed changes in the eligibility criteria for lung cancer screening with low-dose CT that could result in near doubling of eligibility. And, according to experts, this could particularly benefit Black patients. The United States Preventive Services Task Force draft recommendation is available for public comment until August 3rd, 2020. The new proposals include lowering the age at which screening starts from 55 years old to 50, and to reduce the smoking history from 30-pack years to 20. The task force further recommends annual screening for lung cancer with low-dose CT for adults between 50 and 80 years old who have a 20 or more pack year smoking history and who currently smoke or have quit within the last few years. The USPSTF has continued its B recommendation, which allows for coverage of the screening with no cost for many of those who are under the Affordable Care Act. They are also expanding the coverage criteria. So why lower the screening age to 50 years? Lowering the minimum age of screening to 50 would likely mean that more Black individuals and more women would be eligible for screening. The current screening age of 55 is currently recommended under guidelines issued by the American Association for Thoracic Surgery, the American Cancer Society, the American College of Chest Physicians, and the NCCN. Medscape Medical News reported that lung cancer screening in an urban, largely Black cohort yielded roughly double the rates of positive screens and detected lung cancers compared with results from the National Lung Cancer Screening Trial, which enrolled mostly white patients. And although lung cancer risk is greater for men than women who smoke, and although women generally accumulate fewer pack years than men, there is evidence to suggest that women who smoke may develop lung cancer earlier and with lower levels of exposure. The authors of the recommendation therefore concluded that a strategy of screening people who have at least a 20-pack year smoking history and who currently smoke or have quit within the past 15 years, who are between the ages of 50 and 80, would lead to a relative increase in the percentage of people eligible for screening by 81% in men and 96% in women. Now, what's the harm? One of the major concerns about low-dose CT screening for lung cancer is the relatively high rate of false positive results reported in two large-scale clinical trials. The National Lung Screen Trial, which was the basis for the previous USPSTF recommendation, showed false positive rates of more than 26% at baseline, more than 27% at year 1, and nearly 16% at year 2. Dr. Alicia Sequist is Director of Innovation at the Mass General Cancer Center in Boston. She told Medscape Medical News that the false positive results are one of the things we need to think carefully about. According to Dr. Sequist, the potential harm of a false positive can be minimized by having a multidisciplinary team with experience working up lung nodules see those patients who have a positive screen result. In fact, Dr. Sequist pointed out that the American College of Radiology recommends that all lung screening programs be paired with such a team. Despite the clear benefits of low-dose CT screening, however, U.S. screening rates for high-risk individuals are still very low, ranging from 12.3% in Massachusetts to a low of 0.5% in Nevada. Dr. Albert Rizzo is Chief Medical Officer of the American Lung Association. Dr. Rizzo said it boils down to that discussion between the physician and the patient. He said that it would be very good to tell a patient, hey, look, this is what these studies have found, and you fall under a category where if we find a cancer early, it's very likely you're going to be saved, as compared for waiting for it to present by itself. And favorable lifestyle was associated with a reduced risk of breast cancer, even among women who were at high genetic risk for the disease. This is according to results from a study of more than 90,000 women that was published in JAMA Network Open. These data suggest that regardless of genetic risk, women may be able to reduce their risk of developing breast cancer by doing the following: getting adequate levels of exercise, maintaining a healthy weight, and eliminating altogether the consumption of alcohol, the use of oral contraceptives, and the use of hormone replacement therapy. In the study, researchers reviewed more than 91,000 women who were white and postmenopausal in the UK Biobank, which is an ongoing longitudinal study of the contribution of genetic, environmental, and lifestyle risk factors in disease. At a median follow-up of 10 years, the researchers report that 2,728 women developed breast cancer. The investigators used a polygenic risk score to categorize subjects as low, intermediate, or high genetic risk. Within each risk group, the researchers divided women by the presence or absence of 5 lifestyle factors previously associated with a low risk of breast cancer: healthy weight, regular exercise, no use of hormone replacement therapy beyond 5 years, no oral contraceptive use, and alcohol intake no more than twice a week. Okay, let's look at what they found. The data showed an association between breast cancer and a BMI of 25 or higher with a relative risk of 1.14, no regular physical activity with a relative risk of 1.12, alcohol intake at least 3 times a week with a relative risk of 1.11, and the use of hormone replacement therapy for 5 or more years with a relative risk of 1.23. The researchers reported that the use of oral contraceptives was not associated with breast cancer risk, but that this factor remained part of the lifestyle classification. Patients who were in the intermediate group and patients who were in the unfavorable lifestyle group both experienced a higher risk of breast cancer compared with patients in the favorable lifestyle groups. This finding remained true among patients who were classified as being of low genetic risk, intermediate genetic risk, and high genetic risk. You can read the hazard ratios by clicking the links in the podcast notes. This study does have some notable limitations, including that it is unclear how these data apply to non-white patients, non-postmenopausal patients as well. And the authors noted that the analysis did not differentiate between breast cancer subtypes. Additionally, although oral contraceptives have been linked to breast cancer in the past, there was no association in this study. The authors noted that this could be the result of investigators not accounting for the duration of contraceptive use, the age of last use, and the type of contraceptive used. And the FDA has approved Inqovi to treat adults with myelodysplastic syndromes or chronic myelodysplastic leukemia. Inqovi is a new oral combo of decatabine and cedazuridine. The FDA's action gives physicians and patients a new treatment option, which is an oral formulation MDS and CMML medication that can be taken at home. The FDA based the new formulation approval on clinical trials that showed patients taking Inqovi had similar drug concentrations compared with others receiving intravenous decatabine. The two therapies also had similar safety profiles. Fatigue, constipation, hemorrhage, muscle pain, mucositis, arthralgia, nausea, and fever with low white blood cell count were common side effects reported in people taking Inqovi. The FDA noted that Inqovi can cause fetal harm and that both male and female patients of reproductive age are advised to use effective contraceptive. In the clinical trials, approximately half of the patients who were formerly dependent on transfusions no longer required them during an 8-week period. Inqovi is taken as 1 tablet by mouth once daily for 5 consecutive days of each 28-day cycle. And finally, the CDC recommendations on mask wearing says, quote, cloth face coverings should not be placed on young children under age 2, anyone who has trouble breathing, or is unconscious, incapacitated, or otherwise unable to remove the mask without assistance, unquote. That begs the question, does this language suggest that there are indeed patients out there in the adult population with lung disease who should not wear masks? Dr. Albert Rizzo is the Chief Medical Officer of the American Lung Association. He spoke with Medscape to address this question. Dr. Rizzo told Medscape that it's a matter of training the patient. giving them options of how to get comfortable with it, and then making them realize that they have to weigh the benefits and risks of wearing the mask and feeling out the breath versus going out in public and being potentially exposed to the coronavirus. And the bottom line is, anybody who is wearing a mask and starts to feel uncomfortable, they can take the mask off. He said that he won't say that it's mental for all these patients, but he did say that sometimes it's just a matter of desensitizing oneself to wearing a mask. He likens it to patients who have sleep apnea. Oftentimes, those patients need to be desensitized to wearing a mask for sleeping, so physicians tell them to wear the CPAP while they watch TV or just to get used to it, having it on their face. Dr. Rizzo has told his patients something similar about COVID-19. He says, put the mask on, see how it feels, and if the patient becomes uncomfortable breathing, take it off. But maybe the patient can tolerate the mask for 30 or 40 or 50 minutes, perhaps long enough for a grocery run. And that concludes this edition of Run the List by Blood and Cancer. You can click on the links to the full stories in their written form in the podcast notes. Blood and Cancer is produced by MD Edge editor Jennifer Smith. All MD Edge podcasts are produced by executive editor Kathy Skarbeck and vice president Dr. Ivan Oransky. I'm the voice of MD Edge podcasts, Nick Andrews.